I'm Monika Patil. I'm a neonatologist right here in the Texas Medical Center. And despite working in the largest NICU in the country and the largest medical center in the world, this panel topic is close to my heart. And I want to express my gratitude for all of those great minds in healthcare technology, business, and innovation who are working together, because we can't do it alone, to build solutions and progress newborn healthcare worldwide. I'm honored today to introduce our two distinguished speakers for this panel. First, Dr. Cece Lee. Dr. Lee is a Levenger Family Professor of Pediatrics at Warren Alpert Medical School of Brown University and founding director of the Brown Alliance for Infant and Maternal Health Research. She received her BSE in Biomedical Engineering at Duke University and her MD from Harvard Medical School, and an MPH from Johns Hopkins Bloomberg School of Public Health. She completed pediatrics residency and training at Boston Children's Hospital and did a postdoctoral research fellowship at the Hopkins International Center for Maternal and Newborn Health. Her research focus is on perinatal epidemiology and design, evaluation, and implementation of interventions to reduce mortality and optimize the health of mothers, newborns, and children globally. She collaborates with the WHO Department of Maternal, Newborn, and Child and Adolescent Health, where she has contributed to the development of guidelines and novel initiatives for the management of neonatal sepsis and preterm infants. Also this morning, we'll have a chance to hear from Mr. Gregory Dajer. Mr. Dajer is a director and co-founder of Medical Technology Transfer and Services, MTTS, which is a social enterprise specializing in creating appropriate medical devices for neonatal intensive care. His expertise lies in delivering the appropriate medical technologies to those in need, no matter how remote the location. Mr. Dajer contributes, his contributions to the field of social enterprise were recognized by the Schwab Foundation with the Social Entrepreneur of the Year Award in 2017. Together with his team at MTTS, he continues to create innovative solutions at scale with the goal of saving 10 million lives by the end of the decade. I'm looking forward to hearing from both of these distinguished speakers. Please join me in welcoming our first speaker, Dr. Cece Lee.
Great. Thank you so much. It's so amazing to be here today and see so many old friends, partners, and collaborators. I am today going to talk about how we can make big impact in small babies and really think about innovation in our ability to identify those most vulnerable infants. And thank you for the lovely introduction. I am excited. I was previously at Harvard Medical School and Brigham and Women's Hospital for maybe over a decade and just moved to Brown to help them start up a new center that's really going to focus on maternal and newborn health innovation in not only tools and devices, but health systems and delivery of healthcare. So very excited about that. Great. So this slide, many of you may be familiar with, shows just the graphic differences in where newborns are born around the world. While we have about 120 million births each year, only 10 or 11 million are born in countries with access to full neonatal intensive care. On the other hand, almost 90 million are born in low-income countries, either in homes or in health facilities with very limited resources, staff, equipment, and personnel to care for the smallest babies. And we know that this is where most newborns die. This is where we can have the most public health impact with our innovations and with our delivery of improved health systems for newborn care. And this is where I focused the most of the last 2 decades of my career. So I did my pediatric training in Boston, where there are 5 NICUs, and at every delivery, there are at least 4 skilled birth attendants and at least 2 that know how to do neonatal resuscitation. And I did spend a lot of my training abroad, doing a few months. I think Rice has a fantastic program as well. It was just getting started when I was in my training. But I did a lot of time in India and Swaziland, and after residency, I spent much of my research time in Bangladesh and Tibet. And this is the setting that I went from as a senior resident in pediatrics to going to rural Bangladesh, where the majority of the babies in Sylhet, Bangladesh, where I was working as early SLAB innovators know, most of my work was in Bangladesh, where 70% of women gave birth in the home. And the first visit by any healthcare provider was shortly after birth, at the first postnatal visit. This was Vapi, an amazing community health worker that we worked with training for many years. And so I'd say that what I'm going to present today is really on the work that we've done to try to empower frontline health workers and communities to better identify and care for the smallest and vulnerable babies. I'm sorry I missed the first days of the meeting, and many of you are probably already familiar with the major causes of neonatal mortality. We know that there are 2.3 million neonatal deaths globally. These were the estimates from 2022. Preterm birth is the leading cause of all under 5 child mortality, as well as neonatal mortality, followed by intrapartum birth complications and then sepsis. Also, small for gestational age, that is being born less than the 10th percentile of your birth weight for a particular gestational age, is a major risk factor for mortality. It doesn't make it onto the pie, but it is also a huge contributor to neonatal mortality. So the combination of being born either preterm or small for gestational age accounts for over half of newborn deaths annually. Critical is the timing of death and when we can identify newborns and actually get them to care. 2 million newborns die in the first week of life. So that's the vast majority, over 73% of the neonatal deaths. So this just really emphasizes that the early identification of the high-risk infant is critical in order to reduce neonatal mortality. This slide shows the 3 delays to care for the newborn. It's based on the old Deborah Main maternal mortality model, but we have the first delay to care, which is the delay in the decision to seek care. Either the fact that the babies may not be born with a skilled birth attendant, or in the first postnatal visit, there is a health worker that may or may not recognize signs of illness. If they don't recognize that there actually are signs of illness or high-risk signs, they may not actually go to the primary level health facility, primary health center, or the hospital to actually seek the care that they need. The second delay is the delay to reach care, poor roads, poor transport, long distances. And the third delay to the delay of the receipt of care at the facility due to lack of staff, personnel, laboratory testing, and medical equipment. What I'll be focusing on today is really on that decision to seek care and how we can empower health workers to identify signs of illness, signs of high risk and vulnerability that makes the family decide this baby needs to go and receive care. I know so much of the amazing work that's been described today, and hopefully in the following speaker, will be the receipt of care and how we can, what Rice360 does is how we can actually improve the care within the hospitals. But we'll be focusing on that first delay. So the WHO and UNICEF developed the Integrated Management of Childhood Illness strategy in the 1990s. This was a strategy to really empower frontline health workers, either in the community or in frontline primary health facilities, to recognize illness or conditions in the newborn or child and actually provide basic management. This could be either at the community or the primary level health facility level. For young infants less than 60 days of age, a community level health worker will first screen for certain signs of illness or infection. This is possible serious bacterial infection. And there's a checklist of 1 of 7 signs. We just worked with the WHO to do a systematic review to inform their guideline development group to decide, like, are these signs the right signs? What are the sensitivity and specificity of current algorithms? And really try to think about how we could improve these algorithms for identifying serious bacterial infection. The next kind of set of signs that the health worker will assess is, does the baby have any signs of jaundice or hyperbilirubinemia? That's the yellow color to the skin that babies get shortly after birth due to the breakdown of red blood cells and the release of bilirubin. When the bilirubin is unconjugated and in early days, it can actually precipitate in the brain and lead to what we call kernicterus or chronic neurologic impairment, seizures, and also death. The current algorithms ask if the baby has any signs of jaundice in the first 24 hours of life, which is a sign of blood type incompatibility, potentially in hemolysis, or does the baby have jaundice in the palms or the soles of the feet? And that's typically a very high level. So that's the current jaundice algorithm. And then finally, the IMCI algorithm asks if the baby was born not low birth weight, but very low birth weight, less than 2 kilograms, and does the baby have any signs of poor feeding? So I've kind of hinted at some of the limitations of the current IMCI strategy. One, we just did the systematic review. The sensitivity is reasonable in quite several large studies and multi-country studies. Sensitivity around 80%. The specificity a little bit lower, 77%. But if you actually look at the studies which limit that diagnosis to kind of high quality laboratory confirmed sepsis, that specificity is actually quite low, indicating that there would be an over-referrals of babies to primary facilities and overuse of resources, limited resources. Challenges to the jaundice assessment are that very subjective, very low inter-rater reliability. It also tends to identify jaundice when it's too late. When it's at the soles of the feet, that's typically an 18 or 20, and that is almost too late for rescue therapy, rescue phototherapy. Finally, we've mentioned that preterm birth is actually the leading cause of child mortality, and there is no assessment of gestational age in the current IMCI. So I'm going to kind of focus on innovative methods to identify high-risk newborns, and really to focus on how we can empower communities to identify these infants, to really bring them to the health facilities. I've discussed hyperbilirubinemia. The last estimates of hyperbilirubinemia were from the year 2010. We worked with Joy Lon and Vinod Bhutani on some of these estimates, and there are an estimated 1 million babies born with severe hyperbilirubinemia, greater than 20 each year, 75,000 cases of kernicterus, and about 114,000 deaths. If we look at the target year of ENAP of 2030, that means there are an estimated 2.2 million deaths due to hyperbilirubinemia and 1.5 million cases of kernicterus. These are completely preventable and treatable diseases with early screening and treatment. This is very personal for me because 2 of my children, being Asian and ABO incompatible, had very severe hyperbilirubinemia. My son even developing a bilirubin of 20 and requiring about a week of hospitalization at Johns Hopkins. So he's and totally reversible with phototherapy. And this is just treatment that every child in the world deserves to have access to, no matter where they're born. So in most of the settings where I work, have worked in either Tibet or Swaziland, there really is no capacity to do serum bilirubin. There is also no capacity to do transcutaneous bilirubin, which is very easy but it's like a $5,000 to $8,000 transcutaneous device. So I saw the need to really develop a device that could be used to more accurately screen babies in low-level facilities or in communities where there were no resources to be able to do actual serum bilirubin level. We developed what's called the Bili Ruler. This was one of the original prototypes, not the very original, but one of the original. And what you can see is it's a ruler with increasing color swatches of yellow hue, which refer to and correspond with a serum and transcutaneous bilirubin level. And it essentially stratifies the risk of hyperbilirubinemia for that infant. A community health worker will press the ruler against the baby's nose, blanch the skin, and look at the underlying skin tone and match the skin tone to the color of the bilirular. And that will correspond to a serum bilirubin level and a risk level, indicating whether the baby should potentially make the trek down to the or upstream or across the river to the district hospital to actually either get a serum bilirubin level or get treatment. We developed the bilirular by taking many hundreds of pictures of jaundiced babies with a standardized digital photo color palette that you can see there, and using advanced imaging processing pipeline, and also kind of used visual design with the help of some MIT experts to go from our original, Karen Kuhn, you may remember, we originally had vertical stripes, and then we went to circles because they really suggested that would aid in the ease of color matching for especially primary health workers that may have a hard time deciding that simple yes-no binary decision would be easier with this design. In further kind of piloting and testing in the field, the original prototype had sharp edges, and families were like, we really want them to be smooth edges, maybe like a tongue depressor, because it won't poke their eyes when you're doing the reading. So we made smooth edges to make it look like a tongue depressor. And we also added a lighting indicator, because really a target of a lot of this was in use in communities where there's not actually electricity and lighting in many of the houses we are. And it's really important to have good natural lighting for the measurements to be accurate. So we added a lighting indicator as well. We conducted a validation study in about 800 newborns at the Brigham and Women's Hospital and in Salet Osmani Medical College. And first did bilirular measurements in duplicate, then used the transcutaneous bilirubinometer to conduct measurements, and then conducted a serum bilirubin if needed. We found that the measurements on the bilirular, on the x-axis is the bilirular scores on the nose, and on the y-axis is the transcutaneous bilirubin level. But we had high correlation of the bilirular scores to the transcutaneous bilirubin levels. We also found high correlation of the bilirular scores with serum values. And this is for the engineers in the room, or actually I wasn't sure who we'd be speaking to, so I thought there might be undergrad students, et cetera, but this is a receiver operating curve of the diagnostic accuracy of the bilirular to identify jaundice. I chose a threshold that for me is a clinically relevant threshold. If I have a TCB in an ambulatory office that's greater than 15, I want that baby to get a serum bilirubin level. And so that's the value would be similar to a primary health center in Ethiopia. You want them to make the trek to the district level hospital. And so the bilirular had an area under the curve of 0.94 for identifying babies that had that degree of jaundice. And that meant that 94% of the time it correctly identified babies as having a TCB greater or than that threshold or not. And a score of 3 meant that it had a sensitivity of 95% and a specificity of 81%. So overall, the bilirular had excellent diagnostic accuracy for really screening the need for referral for hyperbilirubinemia. So the pathway to scale, there's been a lot of discussions about that. I'm sorry I've missed it, but it's been extremely difficult. It's been a learning experience for me as more from the clinician side. Thank you. We had to go from a shop where I was making it in my basement in my photography shop to a actual reliable and kind of high fidelity color reproduction. And so we worked with another slab innovator, Little Sparrows Technologies, to actually work on the licensing and manufacturing. The regulatory hurdles were also a huge learning process, but now it's a Class 1 medical device registered in the US, Europe, and Canada. And we are also working on external validation in really thinking about increasing the validation in Africa. We have a 5-country study validation that's being done in multiple Gates study sites. It was implemented in a CHW program in Peru, and in Ghana, Kumasi, it's actually being used by mothers, which we hadn't anticipated that use, but they found that there's high correlation with healthcare workers. And there were some amazing other bilirubin diagnostic innovations that came out of SLAB as well. And it's been amazing to see where they are in this kind of scaling pipeline. The BiliCam, I just saw those results come out recently, but that was I guess I saw my time, so maybe I won't go through all of them in so much detail, but an amazing mobile app, as well as Rebecca and Rice360's team with the Billy Spec and then the Billy Stick as well. So I'm going to shift gears now and talk about my next kind of passion, or I'd say sixth child, is really thinking about how to better identify preterm babies born in these settings. We know as clinicians, gestational age is critical for many things. If you're a health worker in the home, a preterm baby, you might want to send them to the hospital so that they can have access to higher level care. Even in tertiary care facilities, recently speaking with a clinician from Cape Town, he's like, this is just so critical because we automatically decide if we're going to resuscitate the baby, if we're going to admit them to the NICU, if we're going to give them caffeine, if we're going to give them surfactant. Or start CPAP, like who they're going to give these limited resources to. But in most LMICs, there's very limited gestational age availability during pregnancy, and it's not known. There are clinical newborn exams to estimate the gestational age of the baby after birth. And the Dubowitz and the Ballard are some of the common newborn exams that have been used to estimate gestational age. They tend to be very long exams. They're 20-plus signs. They include neurologic signs. These neurologic signs are often influenced by whether the baby's sick, whether they've had birth asphyxia, and they're traditionally inaccurate. They date pregnancies within plus or minus or babies within plus or minus 1 month of an accurate ultrasound dating. So this was a blast to the past for the Saving Lives at Birth crew. This was my very first round one slab, which was to really think about developing a prematurity scorecard for our community health workers in LMICs, and to really think about risk stratification, and could we help CHWs stratify whether the baby was early preterm, late preterm, or full term, and really kind of have this feed into IMCI guidelines. We developed this 5-sign scorecard, which included signs like the baby's skin texture, looking at the ear recoil, looking at the breast development and size, foot creases, and foot size. And based on the tally marks and the number of which the baby scored the highest, they would be classified in that color zone. And unfortunately, talking about transparency and honesty, it was horrible. It had poor sensitivity. Sensitivity is 70% and specificity is 27% for identifying preterm infants. This is one where, failures, they are devastating and hard, especially when you spend your lifetime on this. But you have to pick up the pieces, be creative, you have to pivot and figure out how you can use that information to make something better. So we partnered with WHO and several investigators in many countries and thought, can we really approach this differently? The simple scorecard did not work. Can we leverage machine learning to really think about how we can improve the accuracy, but also keep the assessment simple for estimating gestational age? As part of the WHO Alliance for Maternal and Newborn Health Improvement study, we had a newborn gestational age study where the aim of that study was to develop a programmatically feasible and simple approach to accurately estimate the gestational age of the newborn. And that was done in these 5 study sites with our partners shown on this slide here. All pregnancies were dated very accurately were first identified through routine pregnancy surveillance, usually monthly to bi-monthly. We had an early pregnancy ultrasound at less than 20 weeks, and all babies were examined within 72 hours of life. There were a total of almost 7,500 infants that were part of this study. So it was very exciting and well-powered and multi-country study. We assessed the baby for almost 30 different newborn signs. They included physical maturity signs, looking at the creases on the bottom of the foot and the shape of the ear, neuromuscular maturity signs, looking at the baby's passive flexor tone, looking at the hormonal exposure to the flexibility of the joint in preparation for childbirth, looking at feeding signs and the ability of the baby to suckle maturely and breastfeed effectively, looking at the size of the baby. And then we put all of this into machine learning models using a superlearner approach. And so that included an ensemble model of over 20 different statistical models, where each of the models was weighted by the cross-validation and accuracy of those cross-validations. The community played a critical part in the conduct of the newborn exam and also kind of how we shaped the exam. We leveraged the community cadres to actually perform the exam, and we found they could do newborn exam, in particular neurologic assessment, as well as our physicians. And they had high levels of agreement. We also modified the exam based on the parental feedback. There were certain signs that were just really not considered feasible or concerning to do in the home, and we also kind of changed our approach for that newborn exam. This shows the kind of the top 10 predictors of gestational age among that kind of large number of signs that we chose to assess. And the top 10 predictors are on this x-axis right here, and the precision of predicted gestational age is shown on the y. If we look at the model that just had birth weight, that predicted gestational age to within plus or minus 19.1 days of an early ultrasound-based dating. By adding each of the sequential signs, that improved the prediction model accuracy up to 17.3 days. And you can see the majority of signs were based on the baby's size, the first 4 signs. The latter signs had to do with the maturity of the baby, related to the development of physical signs and characteristics, as well as the hormonal exposure to childbirth hormones, which is the ankle dorsiflexion. With our machine learning modelers, if we add last menstrual period to that top 10 sign model, we were able to achieve pretty high accuracy for the ability to predict preterm birth or not. We had an AUC of about 0.91 and a prediction accuracy of plus or minus about 16 days. And that was substantially better than most existing routine methods of newborn gestational age dating. We also found that, for many health systems, doing such an extensive exam may not be feasible. So we did also a model looking at last menstrual period and birth weight, and that model also performed relatively well with an AUC of about 0.88. So also kind of how do you get to the next step? This has taken us a bit longer than we would have liked, but I think we've worked very closely with WHO to try to think about how we can start to bring this to scale and further test and validate. So we've worked with WHO to develop a website to actually be able to implement the model, because the challenge about machine learning models is you can't just plug it into an equation or have an easy scorecard. You need a machine to actually produce the output. So we've now established the web kind of interface as well as a mobile app for our 2 simple models. We presented this at the International Maternal Health Conference last year in South Africa, and this shows kind of what the interface is for the simple model with just birth weight and LMP, and a clinician can enter that and output a gestational age. And we're now in the point where we are starting to test that model in the field and externally validate that. So we're able to find many interested collaborators to kind of help us with that effort in the last meeting, and I'm hoping in the next year that we'll actually be able to publicly release the model. There are other innovations. I think with time, I'm not going to have too much time to mention, but there are other innovations in this space related to kind of machine learning of photos and looking at other physical signs as well. So lessons learned. This has been kind of a long pathway in learning for me as I think more a clinician and epidemiologist, but I think critical is that really centering the design and the innovations around the users and the community that we are attempting to implement. We had so many changes to our prototype and really thinking about how the tool would be used in the health system context that we really needed to think about and come up with different solutions than we originally imagined. I think people have mentioned the iteration and improving on prototypes. We have absolutely learned from our failures and thinking about how we can be creative. The partnerships are key. I think there's been a lot of discussion about WHO, and they have been a key partner in this. Sometimes things have taken a little bit longer because we really need to think about all the regions and partners that are involved in this. But the hope is that with their partnership, that it will actually eventually reach bigger scale. And then I also really did not understand the regulatory complexities of this, especially in different countries. So I think really thinking, has been emphasized in many of the panels, is really thinking even beyond the R&D and original early stages of prototype and validation, is how you're going to actually distribute, manufacture, and think about business, which is something that many of us clinicians do not really feel comfortable with. So in conclusion, innovative tools can improve the diagnostic accuracy to identify small and vulnerable newborns. Early identification is key. The warning signs that can really help link newborns with life-saving care. And I'd say that commitment, action, and persistence are needed to bring technologies to scale and meet the Every Newborn Action Plan to end preventable mortality by 2030. And then finally, I just want to thank all of our many partners here. I know I'm already over in time, so I just have photos of our teams in Bangladesh with the WHO. And actually, the first subject of our bilirular study was my own daughter, who developed hyperbiliary shortly after this photo when we did her measurements, and my family, who really allowed this to happen. Thank you.
So I think one of the things that's really liked about IMCI is that it's integrated. And one of the things we've heard a lot from governments and especially lower level facilities is they're having to make choices about what they procure at that level, especially because there's a lot of facilities to procure for. And one of the requests we've had is to think about integration a little bit more of devices, especially for triage that are meant to diagnose and refer to higher level facilities. So I love the bilirular. But was wondering if you had thought about integrating that with any other existing device or thing that is being used, especially at kind of that level of health centers or health posts, and any thinking around that.
Great, thank you. Yes, we have, I completely agree, and I think that whole procurement is something that we've not done a lot of thinking about. I think we have tried to kind of think about the WHO essential kind of equipment and device list and see if we can potentially partner with them to think about, such as the essential medications list, getting it on that list. But I do think that is the one thing about WHO. They are very rigorous, and we are trying to get more validation in African countries before we push too hard on that, because I, at least personally, would want to make sure it works as well in those settings. But that would be, I think, a great suggestion for next step. So I think in my mind, I want to make sure that we have the accurate diagnostic accuracy in all of the regions in which it would be used, and then thinking about that in the long term. But that's an excellent point, because I think that's what makes the current IMCI algorithm so just able to be used anywhere, is because there's no requirement for a device.
My name is Ekaterina. First, I want to say thank you for sharing your work. It's amazing. I want to say a comment and a question. Like, I can say that as a resident, having to categorize a child at 3 a.m. by the Ballard method was very subjective and challenging. So the gestational age app, it's very, very innovative, and it will be very useful for all the pediatricians and residents. And the other thing, so congratulations for that, it's amazing. And the other thing is that I have seen that there are some diseases that can be preventable before birth, like early sepsis, if, for example, the mom has urinary tract infections. But if the mom is not being like early diagnosed, the baby is the one that suffers. So my question is, will it be possible, or what will it take to implement an algorithm or have a regular approach to detect high risk to the mother as pediatricians working alongside the gynecologist?
That's absolutely a fantastic question, because as we've been working with WHO on kind of thinking about their neonatal sepsis algorithms, are you based in Baylor and high income? Or
I'm from Mexico.
Oh, fantastic. But, for us, delivering in the U.S., there have been many sepsis algorithms where you almost always include the maternal risk factors, prolonged rupture of membrane, maternal GBS status, does she have this infection, et cetera. And in the current IMCI, it's only newborn signs. So it's not, does the baby have it now, but there's no incorporation of did the baby have high risk for it? Did the mother have a temperature of 102? For example, which might place the baby at higher risk. There's a balance because there's a concern for over-treatment. So even in the U.S., when they've done studies of these, earlier, what we call neonatal sepsis algorithms, which included mother's risk of infection and baby risk of infection because of group B strep or maternal fever, they found that there was essentially a very, very high proportion of over-treatment and overuse of antibiotics. And antibiotic resistance is a big concern. But I think the issue is that in a high-income setting, a place like the Brigham or Baylor, where there's generally clean delivery and we have very good monitoring, it's different from like a home birth or a setting in an LMIC where the risk factors for infection are so different. So while they've been scaling back on use of maternal risk factors in the U.S., I do think there still is value, and that's something we have actually suggested to WHO as we rethink about IMCI algorithms, is whether there is any improved validity by actually incorporating maternal signs, because there currently are not in current existing IMCI. But it's funny that you mentioned that, because we actually literally a few weeks ago just suggested maybe we should review this lit and do some modeling with other maternal signs, because the mom and the baby are such a continuum. So.
Question about the Billy ruler, and you only had so much time, so I saw the community data where you did the report. I was just wondering if you see a role for it in the facility and screening of babies in high volume facilities. Definitely, we've come across our share of doctors who have asked for icterometers, and I've been pointing them to you. Yeah. I was just wondering how you feel if there's a role for it, in the facility itself.
That's great. Yes. Oh, definitely. I just don't want to oversell it, but yeah, I think in settings where you don't have any other options, it's definitely better than having nothing or just your eyes. And there's a relatively good correlation with serum as well. I think in particular in primary level facilities, I think of it as like when you're in the primary health center and you're just trying to decide, do they need to go somewhere where they can get a bilirubin or they can get phototherapy. Some people even said, if we don't even have a serum, sometimes they just use visual inspection to decide whether they want to do a transfusion, and I'm like, okay, then in that case, maybe use the Billy ruler, but obviously if there was something like the Billy spec would be better. But right, I think it's like how, whatever technologies we develop, how they reach the peripheral levels is the key question and challenge. But yeah, I would definitely trust it over no other option. But if there were a point of care, and I think this Billy Cam also performed very well. The thing is, you need a mobile phone, and then the challenge we had with that is you need to have a calibration card, because the lighting is so important, and if you don't calibrate it correctly with a mobile app, it's not going to read it correctly. So I think there's challenges of each type of technology, but.
Hello, everybody. Good. It's a pleasure to be here, and it's a pleasure to be surrounded by so many interesting people who are experts in their fields, and we are working together in the field that requires a lot of expertise. So I would like you to, for the next few minutes, to bring your attention, pretend you have a microscope, and focus on one of the aspects of this multidisciplinary field that we're working with. I'll be talking about manufacturing and specifically hardware. So something that is integral part, but we know not the only part, but integral part of innovation and delivering the appropriate solutions for those who need it. None of this will be possible without cooperation. So we cooperate with everybody, and I think this is very important to emphasize that without that, nothing is possible, especially for small organizations like ours, MTTS, that was established many years ago in 2004 and was very narrow in focus and very limited with resources. So the year is 2004, and there is an idea, there's a different world, and a lot of things is what we have today don't exist yet. There's internet, it's just beginning of internet. There's no communication. We don't know what other people do. And especially when you're in a place like in Vietnam, there's just very, very little. You walk into the neonatal intensive care unit and you see the picture like that. For sure, what was guaranteed, there's a lot of babies. There are babies being born, and especially in Southeast Asia, the birth rates are really, really big. And you walk into the room and you see babies, personnel, excited, motivated, always smiling. That's guaranteed in Vietnam, but no equipment and hardware. I'm talking about equipment, hardware. That was the situation in 2004 when I moved there. We see in this picture that there's some sort of equipment. There's phototherapy, kind of a radiant warmer, and this is really an ICU. This is a true an ICU that you can see, and just misery. So the idea is born. We should work on hardware first. And obviously now, 20 years later, we're smarter. We know it's just not hardware, but that's how it was then. 2004 is all about hardware in our case, because we had the personnel, we had people who know how to use the devices, they just didn't have tools. And we know easily preventable diseases can be cured with simple technologies. For some reasons, this is a famous picture, the graveyard, right? Everybody knows it. For some reasons, the situation, this is a picture from Malawi, but the situation in Vietnam was very similar. And I need to take a step back, because in 1990s, I'm not that old, but that's what I heard, there was a notion in philanthropy where win-win situation was created. The second-hand equipment from Western hospitals was donated to developing countries. And everybody thought it's great because we get rid of the devices here, and they can be still used over there. And as we all know, it didn't happen, and it had no chance to happen. And there's many different reasons why it didn't happen, but one of them is related to technology. Technology that the companies, Western companies, embedded in their business models. So the business model, typical business model of medical equipment company today, until today, is the same as you do with printer and printer ink. I think it's very familiar for everybody. You buy the thing at cost, you actually start making money on consumables. And that's how it works until today, and we try to really address that problem from the very beginning. Not easy to break that circle, not easy to address it correctly, because some technologies are obviously taking advantage of the progress in development, but some of them will always require some sort of consumables. So we ask ourselves, what is appropriate technology? What does it mean for us to deliver? In this part of the world, it's very simple. It's a certification. It's a FDA in America, CE mark in Europe. And we can basically close the topic if you are in the US. Very few people want to exceed the requirements because there's no need. They are already difficult. Why would you do more? It takes a lot of time and money to implement, and not only to implement, but also to keep. And we went through that, we know it, and I'm sure many people here also can relate to that. What was interesting yesterday, Dick mentioned that, right? CE mark. It's nice to have, but we don't really think that this is something that we need. And he was right. It's nice to have, but that nice to have is very, very expensive and drives the cost of the devices unnecessarily high. So I will not have answers here, what is good, what is right. There's no solutions here. Regulations are there for the reason. Unfortunately, sometimes regulations is a double-edged sword, right? It helps. It takes care of the user, but at the same time it serves as barriers of entry for everybody else. But it is what it is. We have to deal with that. I just want to share my pain and everybody else who's in manufacturing, because it is a painful process, especially now in Europe, where somebody had an idea to update regulations, and I think everybody who is familiar with the subject knows that the regulations are, companies shifting to FDA for that reason, because CE mark used to be easier, not easy, but easier, and now it's just impossible. And one of the problems is that it's not even the paperwork and complexity, the fact that there's a backlog of applications. Every single device that is on the market with the old regulation, directive I call it, now goes into the regulation that has to be recertified. Recertified every single device. Just imagine the amount of work for those notified bodies, which is a type of regulator. It's just impossible. So it's expensive, long, and I think we have a problem here. So yeah, Houston, we have a problem, right? So this is the reality today. We deal with that out of lack of national regulations in many countries. They just we say, yeah, we think FDA works, CE mark works. We take them in many places, we accept them as our own, and it's useful. So many companies like ours follow those. We deliver the devices there. Some of the countries have their own regulations, but they're almost copies, exact copies of FDA or CE mark. And this is also a little bit difficult, although easier, because the new CE mark, at least, there's a huge emphasis on collecting post-market data that is related to Europe, and I think this is totally irrelevant for the places we're working with. So I have a lot of reservations for CE mark, the new CE mark, as it is now. Those places that have their own regulations, it's a good thing. I think it's a good move, but what it means for us, we have to do certification in every individual country. And that's, again, a painful process, because the paperwork is more or less the same, but actually it takes a lot of time to do it in every single country for every single device. So sharing the pain again, but that's what it is. But we are better than that, right? We have to exceed the expectations of CE mark, because we are not working in Europe or US, where the devices are used in a certain way by very well-trained personnel. Infrastructure, we have to make it better. So the first thing to do is make it durable, that doesn't break quickly. Second step, I like this expression, difficult to use wrong. It's not easy to use, difficult to use wrong means that just make it as simple as possible, eliminate unnecessary functions, yet still satisfying the requirements of the regulatory agencies in Western countries. And here, one good example is a CPAP, because CPAP was taken from ventilators. I think many years ago, you know that the standard was a ventilator in hospital with CPAP function. And the ventilator was used commonly, and it was an expensive device, still is, but vast majority of cases would need just CPAP. So for that reason, to kind of eliminate these unnecessary functions, we could reduce the costs, and we simplify the interface. And altogether, I think it's an amazing example of this kind of development where you design it for difficult to use wrong. Obviously, the device has to be easy to clean and repair, because that those activities are often taken over by people who shouldn't do it. You get the biotech departments in many hospitals, but not always. I know places that those activities are done by nurses, or doctors rarely, but mostly nurses. And this is additional workload and lack of understanding of certain functions, technicality behind the design. It has to be as simple as possible. Everybody asks for be independent from sources as much as possible. Is it really possible? I think it is in some places, some situations, but it's adding batteries obviously is one, and air is easily generated by blowers these days, oxygen from oxygen concentrators, which need electricity as well. So altogether, I think there are solutions available. We use them, but unfortunately, all this adding a bit of cost to the design. And also batteries are another big topic that I don't want to cover here, but you can imagine, you know, that batteries are a weak link in the design very often. We designed the device for imperfect infrastructure. So on top of those extra elements we add in, such as batteries, we add also power regulators. So things that are not required in Europe or US, nobody would even mention that, but here it is important. It's not expensive component, but it does cost some money. So altogether, we have to think of outside the CE micro requirements and regulations. Now, at the end, I put it in non-consumables. Obviously, it's a dream. It's a wish. Maybe one day, maybe, there are going to be materials and designs, but for now, I think it's safer to say a limitation of consumables as much as possible. It's easier with simple devices such as phototherapy, but much more complex with respiratory devices. So altogether, it has to be done cheap. So now, I don't know how many of you are in manufacturing or entrepreneurs, but those who are thinking about it, now we're probably going to think twice. It's a lot of challenges. It's very difficult. It's a pressure. I like the discussion from yesterday also where we wanted to put aside the business. It's not business really. We want to be focused on patient. Patient is the center of all this conversation we have. And I forgot who was it, but it was during the Lina presentation from Gradient. Somebody mentioned that we should sit in one room and do it together and come up with a solution that works, be efficient with resources. And here I have also my reservations because I think the competition is one of the major drivers for improvement. Competition between companies, competition between ideas, and it's a healthy competition. I mean, we have multiple manufacturers here in this room, and I think there's so much need in the world that no single manufacturer is going to satisfy that need. So, and the customer should have a right to choose. In our case, I'm from business school, so sorry, I'm going to be using those nomenclatures. Not really appropriate, I know, but but it is what it is, right? It's a customer is always right, and the customer should choose the best solution, and that's what we want to provide. So that's the technology, and we employ the best brains on the planet. This is the first example of cooperation, because what is MTTS really? MTTS is a locally established enterprise in Vietnam that is me and my wife, many years ago, still together, luckily, fingers crossed, 20 years later. Not an easy thing when you live and work together, but we still, but possible. And we're going on as a small enterprise, and we know our limitations. We know our strengths as well. We are close to the market. We know the customers, sorry, but we know what they need. What are the needs? We are very close. We cooperate with the local hospitals. We got a lot, but we don't get everything. The technology, it's evolving. We need to have access to that. So we work in an organization like on this slide, not only to pick up their brains, but also to get financing. So we work in those directions, and we actually got quite successful. And altogether, we start working on technologies in 3 major areas related to jaundice, hyperbilirubinemia jaundice, hypothermia, warming, and respiratory distress, ventilators and CPAPs. So here are the examples of the developments. It's 20 years. It's a long period of time. We started with simple designs, and there were some technological breakthroughs because I think like this is a great example in jaundice where LED lights came to the picture. I think this is like revolution that is once per century, and jaundice babies got really lucky, really lucky, because jaundice is almost eradicated with LED lights. Before this, we knew that there were certain wavelengths gonna work for breaking up bilirubin, but there was the fluorescent lights that had to be changed every 2 to 3 months, depending on the model. And then we had, again, the consumable problem, right? This is what happened. So LED lights came to the picture in the right moment, for us at least. We benefited from that as a company, and we convinced a lot of people, donors, brought a lot of attention, and that helped us to evolve as an organization and bring the appropriate solution in that area, at least. Then we just start working on some tweaks, and obviously double-sided and canopies to optimize the coverage, and that was the key to success in this area. Warming is the same, start very simple, continue working on improvements, benefiting with progress in technologies as well, different types of heaters. Now we move into conductive warming as well, which is much cheaper device and possible to utilize as well, although not as efficient and not always possible to use as radiant warming. But this is also demand for that. And finally, CPAP. I know we have CPAPs from other organizations, ventilators, but what I would like to talk about during this slide is that we have a lot of old CPAPs now, because our CPAP was introduced as a first device, our flagship product, when we worked together with East Miss West Foundation on a program called Breath of Life over 20 years ago. And that old device, it's 20 years old design. So, and some of them still working. I don't know how it's possible, but almost miracle that they are still working. Not many though. There was a conversation or a question about decommissioning here, and I think that's where we're facing that problem. It's natural cycle of life. Usually devices, when you go for CE mark, those who go for CE mark should know that you have to estimate the lifetime of the device. We estimate 5 years. That's for safety, for our own sake, but we know they are used for much longer. Phototherapy can be used with good LEDs now easily for 12 years, maybe more. And here, the commissioning problem, we start looking. We don't want to end up in the graveyard like everybody else. And of course, the older models have to be replaced by the new ones. And great opportunity for us here happen again. So we start offering the trade-in programs. And we did that in Vietnam, where the older devices we allowed to exchange for newer model at cost. And then it picked up a lot and was a really successful program where we were able to avoid the graveyard and reputational damages to us, and especially help a lot of patients because the new technologies as they are appearing are much more superior and useful. So this is a true win-win situation. I always think that for any organization, the people are the most important. And we started with 5, me and my wife, a few other guys, but at the end we were expanding as we were receiving contracts, convincing people to invest in our technologies and our ideas, and we were adding more and more resources. And being in Vietnam in 2004, trust me, was a challenge to find talent. Talent in the areas of biomedical engineering. There's a lot of clever, smart people in Vietnam, but there was no a single biomedical engineering course at that time. So we were looking outside. We were approaching many different institutions, and Rice, we had how many? I think six graduates coming to Hanoi working with us. Some of them came for 6 months, stayed for 2 years. So it was really also, I think that's how I measure a success. I think they like it. There's a lot of things to learn. and they contributed enormously to our program. Voice of customers, they work on design activities, they work on activities related to medical, not only medical, but clearly technical, electronic items that are also outside our expertise. So we had to have everybody who have different skill sets and make sure that we get the products developed, continuously developed, improved, and bring it to the market. Because if you don't continue improving, you basically can close your business. I think this is going to be always have to happening because of the improvements, the new technologies coming, and also what is happening on the market, the competition. That's why I think competition is very, very important. So there are some examples here of what's happening here with our devices, but this is my favorite picture. This is your own Kelly Maynard from Rice. She came to Hanoi in 2012, if I remember correctly. And she was not only involved with the design development, but also traveling a lot around the region and installing the devices, training on them. This is very old ones, so all the old models. Philippines General Hospital in Malate, in Manila. And that was one of our bigger orders at the time. And I think this is something that can inspire younger generation, younger students if they are here, because we think this is a great way of learn on the job. And MTTS is manufacturing entity, so we are good at training, implementation, bringing the devices to the customer, but we don't have resources to do that. Because if we add those costs to the price, then many people don't understand. This is going to be too expensive. So what we start doing is working with different partners that are good at it and have resources, and took us through years to different locations. And here are from small organizations that work only in one country to very big ones working in the many, many different locations. We deliver that through different channels now. Most the arrows the thickness of the arrows indicate the flow. So our major flow goes through distributors, sometimes directly to hospitals, but we still work with NGOs. And the road is tough. It's really tough. And getting tougher and narrower, where people just use bamboo sticks and bring it to the clinic. And sometimes there's no road, and you have to take a helicopter. And that happened to us with our programs as well, and that was actually quite fun. And I have to speed up a little bit because time is up, but I just want to pose that question, is that universal solution really possible with technology that we talking, that is it one size fit all possible? I don't know, I'm not going to answer that question. I have my theories, but I want to let you start thinking about it. But I just want to show this how we try to approach that. And we have the device that is good, but there's always a but. There's something but. It's designed from the context, but it is not suitable for everybody, right? This is tertiary level. The device is easy to use, yes, but training is still required. You cannot just parachute it somewhere and say goodbye. Easy to service, yes, but training or support will be required as well. Then we have independent of sources. Yes, it is, because it has battery, has an onboard air compressor, but it doesn't have oxygen concentrator, and it needs power from time to time. Non-consumables, yes, because you can disinfect the breathing circuits, but still, cannulas, in our case, or whatever interface you use, not yet. You still have to dispose them. Robust, sure, but maintenance is required. If you don't do maintenance, no matter what's going to happen, the device is going to break. It will break. So altogether, we created the network of supporters. This is the theme on this presentation. We are just a tiny, tiny mosquito on this massive, massive the ecosystem. And the things that we work very hard is to build the relationship with those organizations that are listed here in those areas that allow us to bring the devices to the customer. So just quick example of one specific example. We opened assemblies in Ghana from Vietnam, thanks to Grand Challenges Canada grant, and I think that was considered great success. Still working. Indonesia is just a plan. I think it's our next step. And the impact we generate now is over 150,000 children treated per year with our devices. We reached over 17 countries. So I think from really nothing in 2004, it's quite proud of that. And quickly about the future. It's a blank space. None of us know. Tabula rasa, yeah? I wanted to stop here, but then I had to put something, and I thought, we keep talking for 20 years, and sometimes feel sad about it, because we keep talking about it for 20 years. I think we already know that the hardware alone is not sufficient. We already agreed on that. No need to continue talking about it. But the same unsolved problems, I'm tired to make the same mistakes. It's time to start make the new ones, right? You know the Bridget Jones that she was talking about. Let's start make new mistakes. Okay, we have to start thinking about the box. But what's going to happen is definitely going to be higher expectation from users, because the technology, everything that is around it, new technologies allow the better performance of devices. And the expectations have to be higher. We have to start to address them. We have a lot of things that are going to be changing. In the design itself, it's going to be efficiency of the design. So I think that's going to help us a lot. This is what we have to be ready. And finally, we looking forward to more exciting partnerships, because we know you cannot walk alone. This is going to be a team effort, and I think that's what we're going to do. But most importantly, this is going to have to be cheaper. So everybody expects that, and that's where efficiency, cost reduction is going to come to place. And that's where we're going to put most of our efforts to. Thank you very much.
I'll kick things off. You brought up the issue of decommissioning, and only because it triggered something in my brain. I'm curious when you said training, I thought one thing, and it sounds like for you decommissioning was you leveraged that as the opportunity to swap out the technology and when you would come in and do the training. But what do you currently do with the technology that you take away?
Yeah, so this is exactly the opportunity came when we had the new technology. We would never offer the trade-in program if you didn't have alternative. Mm-hmm. So that's definitely a requirement. So what we do today is all our existing technologies are not old enough yet to offer decommissioning. Mm-hmm. But we are improving them, and we are ready. We're going to be ready in time to offer trade-in program when those existing technologies are going to be too old to use. So this is going to be like an ongoing process. And I think this is what people are looking forward to, and that's what makes the product attractive as well.
Mm-hmm. So, and I'll just throw something out there, and this is not anything that any of our colleagues in our Invention Education Network have mentioned, but I think about whenever we're doing our work at Rice360 and we have our design studios, I know how much we spend on supplies in these design studios, and we're teaching labs, and even when we purchase the equipment that we evaluate through NEST, and I wonder if these technologies are in countries, is there an opportunity, and this would be a question I put out to our colleagues that have design studios, if there was a donation model, could these decommissioned technologies be something that could be used to train BMETs or future biomedical engineers, so that things that they can take apart and break apart and learn from, in that way, at least in that form, even if they're, I understand there's a certain amount that probably could be recycled, but if components are broken, just something to throw out there to the community.
Yeah, but in our case, we decided to take them back, because we worry that what's going to happen to those devices if they stay. They may keep using them. They may, do all the things that we don't want to, and it was simply safer. But once it's in our hands, we can do absolutely anything we want. And I think there's probably better use when we were just taking whatever was possible to take from that, and the rest was dumped, recycled with the other materials. But I'm sure there is a better use of decommissioned devices. Yeah.